What you need to know to be prepared for radical cystectomy for the treatment of bladder cancer. Let's review the anatomy of a urinary tract. The urinary tract is comprised of the kidney, the ureter, the bladder, the urinary sphincter, and the urethra. The kidney's job is to filter the blood and produce the urine. The ureters carry the urine from the kidneys to the bladder. The bladder stores and empties the urine, and the urethra carries the urine from the bladder to the outside of the body. The bladder wall is made up of a number of layers. The outside layer is muscle, followed by a connective tissue layer or lamina propria, followed by the inside layer or urothelium. Bladder cancer is the 5th most common cancer in men and the 8th most common cancer in women. It's most commonly related to tobacco exposure. 2/3 of patients of bladder cancer present with non-invasive disease, whereas 1/3 present with more advanced disease. Staging of bladder cancer is determined by how invasive the bladder cancer is. Superficial tumors are described as TA or T1, whereas invasive tumors are growing into the bladder muscle and sometimes into the fat tissue surrounding the bladder. Low-grade bladder cancer is the least problematic. High-grade bladder cancer tends to progress and be much more aggressive. The problem with bladder cancer is that it has a high recurrence rate. It tends to come back even after treatment. You also can see a possibility of disease progression, where the disease invades deeper and deeper into the bladder wall and even spread to other organs. The indications for surgery with bladder cancer are invasive bladder cancers, and then select patients that might have high-risk, non-invasive disease. Patients that fail BCG therapy that have non-invasive bladder cancer or carcinoma in situ may also be candidates for surgery. There are a number of other treatment options available for muscle-invasive bladder cancer: neoadjuvant chemotherapy, followed by cystectomy and urinary diversion; trimodality approach, which is bladder sparing, which involves maximal transurethral section of the bladder tumor, followed by chemotherapy and radiation. Non-curative palliative local therapy is repeat TURBT, or transurethral resection of bladder tumors, and in some cases, no therapy, and just supportive care, comfort care, or hospice for terminally ill patients. The male anatomy is comprised of the bladder, the prostate, the penis, the urethra, the testicle, the epididymis, the vas deferens, and then behind the bladder, the rectum, the seminal vesicles, and the anus. In a radical cystectomy, the bladder is removed, the prostate and seminal vesicles are removed, sometimes the urethra and pelvic lymph nodes. After the bladder is removed, a urinary diversion procedure is performed. This involves the creation of an ileal conduit, a neobladder, or a continent cutaneous pouch. The ileal conduit or ileal loop is the most common type of urinary diversion. It's also the simplest. A segment of intestine is harvested by the surgeon, and it is constructed to have the ureters then drain the urine into the conduit, and the urine is drained continuously into a bag that is attached to the abdominal wall. What are the advantages of ileal conduit? It's technically the easiest surgery to perform. It's a shorter operation time. There are no need for external tubes. It's easy for patients to learn how to manage the bag. The bag will need to be drained every 4 hours, changed every 4 to 6 days, but there are no physical limitations with ileal conduit. The disadvantages of ileal conduit could include an altered body image, the possibility of leakage or accidents with urine, the need to carry supplies, these appliances, a change of clothes, and sometimes it can be difficult to hide. Neobladder is another option with radical cystectomy, where a segment of intestine is harvested. The bowel segment is reconfigured into a spherical pouch. Then, this pouch is connected to the urethra, and the ureters are connected to the pouch. Following the neobladder reconstruction, you will leave the hospital with some temporary tubes, a urethral catheter, a neobladder tube, and possibly a drain. It will be important for you to relearn how to urinate. You will need to learn to activate and bear down with your abdominal muscles to squeeze the neobladder. You'll need to strengthen the urinary sphincter to improve continence. And sometimes you will need to intermittently catheterize the neobladder. Catheterization and irrigation in the neobladder is important to also prevent mucus from building up and plugging the urine tube. The advantages of a neobladder: no dramatic change in body image, there's no need to wear an appliance or a bag, and you can urinate in the toilet as you did before surgery. The disadvantages of a neobladder is that surgery is longer. It's more work for the patient postoperatively. It has a slightly higher complication rate. There's a greater risk of incontinence, especially at night, and a higher rate of diarrhea. A continent cutaneous pouch is rarely ever performed, and it's a pouch made from bowel with connecting segment to the skin. A catheter is inserted every 4 to 6 hours to empty the urine. It's often performed in younger patients who must have the urethra removed. It carries with it a higher rate of stomal complications, a risk of incontinence, and a risk of stone formation. Non-orthotopic continent diversion is displayed here. This shows the pouch made of bowel with a catheterizable stoma that's attached to the skin. There are risks with this surgery: bleeding, requiring transfusion in about 50% of cases, rectal injury in 1 to 2% of cases, which may require a colostomy, infection, nerve injury, worsening kidney function, blood clots, heart attack, stroke, pneumonia, and death. Risks that may be seen later are urinary tract infection, potential for bowel obstruction, ureteral obstruction, stomal stenosis or hernia, urinary leakage. Erectile dysfunction is very common, and a loss of penile length or curvature. The surgery takes approximately 4 to 6 hours to perform. Another 2 hours may be needed for the creation of neobladders or catheterizable pouches. Additional time may be needed for more complicated cases. The surgical team will try to update the family during the procedure to keep them informed. Following this surgery, the patient may have no food or drink until bowel function returns, which is roughly in 3 to 4 days. You may have a tube in the nose to drain the stomach for 1 to 2 days, and there's nothing you can do to speed up the return of bowel function. To prevent blood clots from forming, external leg pumps that squeeze the calf muscles are used, as well as the injection of blood thinners. To prevent pneumonia, it's important to use the incentive spirometer to help you take deep breaths. Pain control will be managed with the patient-controlled button to administer pain medication, and walking is the fastest route to recovery. Patients will have a drain placed at the time of surgery. For most patients that have an ileal conduit, these drains will be removed before discharge to home. Some patients will go home with the drain and will be taught how to empty and measure it. Patients that have the creation of a neobladder will have a urinary catheter placed that they will go home with as well. The hospital course is roughly 7 to 10 days. You are not going to be able to be discharged to home until a patient can eat regular food, pass gas, have bowel movements, are able to be up, walking regularly, be able to use the urostomy after meeting with the enterostomal therapist, and have their pain under adequate control. In patients that have a neobladder, you will need to learn how to irrigate the tube for when you leave the hospital. Full recovery after the surgery is about 8 weeks on average. Patients should be able to walk around their home and go up and down stairs with ease. You can shower when you get home, but avoid bathtubs. You will go home on oral pain medication and stool softeners. You should expect that during this process you will lose some weight, and food will often taste a little different for a while. If you have an appliance, don't be surprised that it tends to fall off at the most inopportune times, so please carry an extra appliance with you. Patients will report that they have diarrhea for a few weeks after discharge from the hospital. If you become constipated, you can try Miralax, milk of magnesia, or magnesium citrate. It's important to limit your activity and not lift anything heavier than 20 pounds for the first few weeks. You can generally increase by 5 pounds per week. No tub baths for at least 2 weeks. You should not drive for at least a week or two after surgery and will need to be completely off narcotic pain medication to do so. You can expect to be off of work for 6 to 8 weeks, and we will assist in filling out FMLA paperwork for you. The other things that you can expect to see is that your urine will now have mucus in it. You may see blood in the urine for weeks to months. This is a big surgery and a big recovery, so you should expect that you will get tired more easily. You should take naps as needed, increase your activity level every day, and keep up your walking. Please call your doctor if you notice a fever greater than 101.5, any chills, redness or drainage from the wound, any leg swelling or pain, severe pain that is not adequately controlled by pain medication, any nausea or vomiting, constipation that is unresponsive to laxatives or severe diarrhea, as well as shortness of breath. If you have problems with the stomal appliance, please call your enterostomal therapist. Relax, it takes time and it will get better. As you heal, the appliances may change and actually get easier to use. Your chance for cure will depend on the final pathology from the bladder and the lymph node tissue. The pathology report will take about 7 to 10 working days to get the results, and most times the patient is already home before the pathology report comes back. Your surgeon will have their scheduler contact you. You will need medical clearance with your primary care provider or internist. This will include a history and physical exam, blood work, an EKG, as well as a chest x-ray. You will then be contacted with a surgical date as well as instructions of where and when to report. The pre-authorization process is essential. We will communicate with your insurance company to determine your coverage and any co-payments or deductibles that you might owe. We'll provide you with an estimate of any charges that you might incur. All these charges are due prior to the procedure, and payment plans can be arranged if needed. Preparing for surgery, it's important that you continue to eat healthfully to help with your healing from this major procedure. Bladder cancer patients commonly will have poor nutrition status as these cancers consume a large amount of nutrition. You may want to consider using supplements like Ensure or Boost. It's important to keep positive and keep active. We will give you a bowel prep starting the day prior to your surgery to clean out the bowel, similar to what you get with a colonoscopy. You may have clear liquids, but nothing to eat or drink after midnight. A chlorhexidine shower is recommended the day prior or morning of surgery, and this special soap can be purchased at a local pharmacy or your surgeon may give it to you directly. You will need to see the enterostomal therapist prior to surgery to have your abdomen marked for the appropriate placement of your stoma and to be educated about a urostomy. If you underwent pre-operative chemotherapy, we will coordinate with your medical oncologist to make sure that your body is adequately healed prior to surgery. The hospital will call and discuss medicines to take the morning before surgery. And if you're taking a blood thinner like aspirin, Plavix, Coumadin, Xarelto, or Eliquis, please let your surgeon know as they will need to take special precautions. Arrive early for your surgery, at least an hour before the scheduled appointment time. Both your prognosis and recurrence rate with bladder cancer are dependent on you not smoking. Your risk of recurrence is much higher if you continue to smoke. You must stop smoking. If you need help stopping, there are a number of things to assist: medicines, nicotine replacement, psychotherapy, and hypnosis. Please discuss these with your urologist as well as your primary care physician. If you need further help, please reach out to the Bladder Cancer Advocacy Network, BCAN. We hope that your procedure goes as well as possible and that you have a speedy recovery. We sincerely appreciate your feedback regarding your procedure, as we're always trying to improve the care that we provide to our patients. Should you have any questions regarding your procedure or recovery at any time, please contact your doctor. Thank you.